Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
In today's episode, we continue to highlight our conference speakers and presenters. Today, I will be talking with Dr. Kimberly Durant. And at our recent virtual conference, she and her colleague, Ashley Crew, presented on the topic Bridging the Gap Between Pelvic Health and Orthopedic Physical Therapy. Dr. Kimberly Durant has been a physical therapist for the past 10 years, treating in mostly orthopedics. After receiving her degree from Gannon University, she attained her orthopedic specialist certification from the APTA in 2016. Her commitment to learning led her to complete a fellowship in orthopedic manual therapy at Regis University in 2018. Dr. Durant has been teaching orthopedics to physical therapist assistants for the past 5 years for 2 PTA programs in Maryland. Over the past 2 years, Dr. Durant has taken further continuing education to treat pelvic floor dysfunctions. It's my pleasure to speak with Dr. Durant today as she brings to the forefront the importance of orthopedic therapists having confidence and basic knowledge in treating the pelvic floor. And with her expert colleague, a women's health specialist, she presented a very effective course, helping to shed light on an area that some people find intimidating, but certainly important to the overall function and outcomes of many of our orthopedic patients. Dr. Durant, welcome to the podcast.
Thank you so much for having me. I'm really excited to be here and to talk further about pelvic health and orthopedics.
To kick us off, can you tell us a little bit about your story? What got you passionate about this topic, or what it was that had you bring it into your practice more prevalently?
Sure. I completed my fellowship in manual therapy with Regis 3 years ago. Shortly after I finished that, I had a really dear friend that is also a fantastic pelvic floor PT. Her name's Megan Music. She started telling me, like, there's this whole world we're missing out on. And I kind of blew her off. I didn't think anything of it. And then she kept giving me more and more resources as to this is a huge world that we're missing out on, and we need to be integrating these orthopedic and pelvic floor. So, long story short, I started taking external courses just to kind of get my foot in the door and kind of see what was out there. Not a ton of external courses, honestly, available to us, but they're still out there. So I started taking them and I started asking people further questions about pelvic health. And people were just I was amazed at how many times I heard yes to questions that I thought I was going to hear no to. Like my patients with low back pain that I asked if they had any leakage and they would say yes. And I would be like, oh my goodness. So there's more of a correlation than I really thought there was. And I couldn't get over the amount of gratitude those patients had that I asked them further questions because I was one of the first providers or one of the first medical people to actually ask them further questions. And they were so unbelievably grateful for any information I gave them. And in the beginning, and even now, it's not like I'm giving them a ton of information. I'm just giving them just a little bit of insight. And they're so appreciative. So with that, kind of just made me want to learn more and more and more and just want to help these people. And I eventually went on to take internal course as well. So I have that. But I am nowhere near a pelvic floor specialist. It's just something that my love is always ortho, but I think it's definitely a world we need to be integrating with all our ortho patients. I think there needs to be a breakup of this segregation of either you're an ortho or you're a pelvic floor therapist. There needs to be a better relationship between these two worlds.
Absolutely. The regional interdependence. We're not chopped up into little compartments like we like to compartmentalize body parts in Western medicine. I agree with that.
Exactly.
We'll get into some questions that you ask patients later, but can you tell us who should be thinking about the pelvic floor when evaluating and treating an ortho patient?
Pretty much, we should be thinking about pelvic floor with all the orthopedic patients This is not something we ask these questions just to the stereotypical individuals that we think will have some kind of pelvic floor dysfunction, like our postpartum geriatrics, our females. Like, we need to start thinking of the whole picture and appreciating that there are men that have pelvic floor problems, there are athletes that have pelvic floor problems, that it shouldn't be just a certain demographic that when we get the script that says low back pain, oh, okay, that's when I screen for pelvic floor. And Ashley in our course at the conference did a beautiful job of explaining this, that even with our post-op ACL reconstructions, we have to also be mindful of potentially pelvic floor dysfunction, that they might be over recruiting their obturator internus and not really recruiting well, and then developing a pelvic floor problem. So it's a matter of thinking of it all the time, which is different for us, at least for me. When I graduated PT school 10 years ago, that really was the emphasis. It was more of what I just said in terms of the stereotypical demographics. You look at it, it's a change in mindset we have to include everyone.
Can you get into a little bit more, just briefly, some of the key aspects of our own anatomy that make this so central and important to treating people with low back pain, hip pain, and as you even said, the ACLs and the athletes? What are some of the key features that the pelvic floor is central to?
The main thing is that we need to be thinking about the core in a different mindset, and that we need to integrate the pelvic floor with the core. We really can't have, quote unquote, great core without having a good, strong pelvic floor. So we know that there's an intimate relationship of the diaphragm and the pelvic floor and our breathing pattern. So whenever we exhale, ideally, our pelvic floor will contract and lift. And when we inhale, ideally, it will lengthen and lower. And there's been some good studies in terms of looking at people with chronic low back pain, and they found that their diaphragm does not move the same extent as someone without chronic low back pain. Also suggesting that there's a nice relationship between our breathing pattern and then chronic low back pain. And we know about the relationship of our diaphragm with our pelvic floor. So it's integrating all these systems together to make sure that we're seeing a good recruitment pattern when we tell someone to do a core exercise. So they're making sure they're not holding their breath, making sure they have awareness of their breathing pattern, and that they're exhaling during the most strenuous part so that pelvic floor can come on and breathing pattern can come on. So if we're not integrating some kind of breathing pattern or some kind of cueing for pelvic floor while we're retraining our low back patients or patients, any kind of patient we're trying to train with core, are we really getting the whole system? And I would argue no. Two famous PTs that are really big into that are Susan Clinton and Julie Weeb, have a lot of information about that. So I'm not doing it justice with my little blurb that I'm talking about right now. So if that's something that interests you, they have a ton of resources about that.
Oh, great. We can put that in the show notes, their names, so people can dig into that deeper if they wish. But in framing it like that, now all of a sudden we're right back in our wheelhouse as orthopedic physical therapists because we're training neuromuscular rehab and integrating the motor system for functional movement. So that might take away some of the scariness for people who haven't really thought about or know what to do with the pelvic floor. In that vein, can you debunk some of the common myths that ortho PTs might have about treating the pelvic floor?
Yeah. So I think a lot, especially when I first started treating this, and this is, like I said, this is something that's relatively newer to me as well. I was under the assumption that I was only going to be able to help people internally. Like, I was only going to be able to help people if I took an internal class. And that is false. You can really help a lot of people just with providing them simple education about what is typical for urination, what's typical for bowel movements, what are things that can help with this, what are positions that can help. So it's not you have to be trained internally to make a change with these patients. You can certainly have extensive external treatment for simple pelvic floor dysfunctions. I'll make that caveat, and really make a change with patients with these issues. And the other thing is that I think, and the APTA is moving towards this as well, is thinking of pelvic floor for men and female, for everyone, not just associating it just with female. And APTA just recently switched over their subsection to be pelvic health instead of women's health. So there's already this kind of push and initiative to get out of that mindset. This is just a female problem, or people that identify as female problem. It's everyone has a pelvic floor. So therefore pelvic health is important to everyone.
Yeah, I'm sure women have a fair amount of it, and we think of postpartum. So there's a fair amount of trauma that goes on with that. But you're right, there's plenty of men that have dysfunction, and it's a little more taboo, probably even more for a man to admit some issues with incontinence or leakage or even pelvic pain.
Exactly.
All right. So, one of your objectives in the conference presentation was to define the current evidence and relationship between pelvic floor dysfunction and other musculoskeletal conditions. Can you give us a brief overview or insight into the relationships that you wanted to make sure that your participants in the course were understanding?
Yeah, so there's two studies that I mentioned, and they're bigger studies. And in the course I mentioned, and I'll mention it here, is that of course in physical therapy world we're lacking the amount of evidence of most things. I think low back pain is the one thing that we have a decent amount of research on, but in pelvic health there is really a lack of research. It's an area that we definitely need more help developing and proving. But with that, there are two really good cross-sectional studies that I have found, and there's a few other ones that get mentioned a lot. They're just a little bit older that looked at the relationship of low back pain and pelvic floor pain. I believe that one was in 2008, but the most recent one was done in Canada. It was in 2017. It was by Cassidy et al. And it looked at 125,000 patients just to see what the relationship between low back pain and urinary incontinence. And actually, they looked at it from the other side. That what was the relationship of if you had urinary incontinence, what was the likelihood that you were going to experience low back pain? And what they found is that it doubles your risk of developing low back pain. And what's so interesting about this study is that it was the same risk for both men and female. So again, getting away from that stereotypical demographic, men had the same odds of having low back pain compared to the females in this cross-sectional analysis. And then the other study was a smaller subject set, about 2,500 patients in Kentucky, and they looked at the likelihood of developing stress urinary incontinence if you had low back pain. They found that odds of having stress and urinary incontinence increased by 44% for female with chronic low back pain. So almost half, which is crazy. So if we think about our patients with chronic low back pain in the clinic, and how many of those probably also have some kind of form of urinary incontinence, and we may not be asking them the right questions and knowing that they're also having that problem as well. It kind of goes back to our core discussion of, okay, are we really rehabbing them the best way then, if they also have that history?
That's really good insight. I'm typically very good about asking the clearing questions for making sure they haven't had bowel and bladder dysfunction related to a significant neurological dysfunction, but probably am not asking deep enough questions to get into some of this type of dysfunction. For those of us that might not be asking the right questions or enough questions, what are some key questions that you're asking during your screening of a typical ortho patient or typical low back patient?
There's a lot of things that you should consider when we're thinking about, okay, potentially this could be a pelvic floor dysfunction as well. And one of the most helpful ways that I have found, and honestly takes a little bit more time, is having follow-up questions on your intake form, asking about urination, bowel, sexual function, and trauma right on your intake form. So that way you don't have to ask the questions, and it kind of opens the discussion a little bit more organically compared to just going down the line and just asking the questions. So urination, how often do you urinate? Do you experience any leaking? Do you have any leaking with laughing, coughing, sneezing? And these can all just be check marks that they can just easily say yes to, rather than maybe being slightly intimidated and just saying no whenever you're formally going through your history. I find it's a little bit helpful to have it in the intake because it just opens the conversation better. But you can certainly go through them as you're doing your history, but just going a little bit further into it, more so than just asking any, the generic, do you have any bowel or bladder problems? I feel like most patients, when they get that question, they're like, no. So it's very helpful to kind of have in the back of your mind other follow-up questions you can ask. So similar to what I just said, like, do you have any leakage? Do you have any problems initiating urine? Do you have any pain with urination? Do you have any hesitation? Do you have any leakage? And then from there, you can go off of and start asking about bowels. How often are your bowel movements? And you can pull out the wonderful Bristol stool scale and get a sense of how their bowels are. Are they super watery? Are they super constipated? Or are they somewhere in between? That's a good resource to kind of look at and see if there's a problem there. And then go into similar questions. Do you have any pain with bowel movements? Do you have any incontinence with your bowel movements? Ashley talked about this a little bit in our course, but talking about trying to get away from using the word incontinence because it's a very all or nothing thing that most patients think of either I have incontinence or I don't. So even having a little bit of leakage or smearing of your bowels could be considered incontinence, bowel incontinence. And then once you move from bowels, asking about sexual function, like any pain with sex, any pain with tampon use, any pain while having a pelvic exam, can lead you into potentially, is there an issue? Is there a tightness in that pelvic floor that's potentially causing issues? And then, of course, also asking about trauma. And I like to put that on the intake form as well, because again, that sometimes can be a question that trauma survivors will initially say no if you verbally ask them, but might say yes if you put it in a form. Just trying to get all the functions of the pelvic floor. You can certainly ask through the intake, or you can ask further when you're doing your history, whatever you kind of feel comfortable. Like I said, I felt more comfortable when I was starting out, just putting it on my intake form and then letting that lead the discussion rather than go through every formal question that I just said.
Your colleague Ashley Crew had mentioned some situations where there is a true pelvic floor dysfunction due to the excessive tension on ligaments in the pelvic floor region. It can cause back pain. Can you elaborate a little bit or give us a little information on that when the patient will come in and complain of a low backache, but it's not actually the spine as much as something going on in the pelvic floor region?
Yes, so Ashley did a great job explaining this because I think this is something we typically all see and we should be mindful of. Patients with low back pain that potentially are related to the disc present very similar to a patient that might have prolapse, meaning that as the day goes on, they get that heaviness, that pressure, that discomfort in their low back. And so you could easily mistake that for discogenic or just chronic low back pain. It's an easy thing to kind of screen for in terms of what else could potentially be causing that. You can ask, do you feel heaviness in your pelvis at all, to make sure that it's really not a prolapse that's potentially causing that. And then you can go further into what we just mentioned, your pelvic floor history questions in terms of problems initiating urine, problems initiating a bowel movement. All those could potentially lead you to be thinking perhaps more a prolapse. You can also use, if you're also on the camp of, I don't know if I feel comfortable asking those questions, you can also use the Pelvic Floor Disability Index, which the first section of it just asks prolapse questions. So if you give them that questionnaire and they score pretty high just on the prolapse, and there's questions that, similar to what I just said, heaviness in the pelvis area, they ask further about prolapse. So if they score really high on that, then you could probably be pretty sure that there's a pelvic floor dysfunction and maybe a good chance they have prolapse. And at that point, that would be a reason for a referral to a therapist with internal training. Because anytime with a prolapse, you want to be screened by a therapist that has internal training to kind of get an idea of what the grade of that prolapse is.
Are there any other patients that you can think of that we need to be sending to a pelvic floor specialist?
So if a patient obviously comes in with, and their main complaint is pelvic floor related, obviously they need to be referred to a pelvic floor therapist. I'd say chronic pelvic pain should really be handled by a pelvic floor physical therapist. Significant pelvic history, like pregnancy history, trauma, your more complicated cases should be sent to a pelvic floor therapist. But ideally, patients with, urinary incontinence, that maybe that's not the reason why they came in, but you start digging and you find it, those are patients that certainly can be treated externally for the most part. There's exceptions to that. I don't want to make that blanket statement, but they can respond well to just external treatment. So it's not something that just because they say they have some history of leakage that they should immediately be sent to a pelvic floor therapist, because as we know, we don't have that many to begin with. And there's still so much of our background of being orthopedic PTs that we know if we can still help them with. As a whole, anything that seems a little bit beyond your comfort zone or just a little bit too complicated or just really extensive history probably would do better with a pelvic floor PT.
That's helpful. Thanks. And I want to go back to our comfort zone with our low back patients. Can you give us a little mini case or story of a patient who was referred to you or you've treated that had some pelvic floor issues that you did address and how that improved their outcomes? Giving us a good insight into how we can integrate this and how it impacted the patient's outcomes for the better or improve their timeline for treatment.
So I currently have a patient I'm treating. She was treated at a different facility for some time. She was post-op L4, L5 fusion beginning in the year. So she was treated traditional, like post-op fusion, like core coordination exercises, eventually transitioning into walking tolerance, flexibility. But she was referred to me because she was having a lot of urinary incontinence, especially at night, and she wanted to know what else she could do. So I wanted to see kind of like how was she able to contract transverse abdominis? What was her core exercises she was still doing? And what I found was that she was just using her breathing pattern in the opposite way. When she would go to do anything that was core coordination, she would hold her breath and put way too much pressure on pelvic floor and on diaphragm. And with that, unfortunately, kind of developed a pelvic floor dysfunction. So what we did with her was a lot of kind of educating with breathing pattern. Okay, how can we get the breathing pattern in sync with our core coordination exercises? Now we know the fundamentals of them. Can we put the breathing pattern with it so we're not using a poor strategy and we're not putting more pressure on pelvic floor? So that took a little bit of time for her to get used to, but it was something simple for her to understand. And then as soon as we started doing that and just slowly started loading her up to the exercises she was doing previously when she was in PT, her pelvic floor responded quite well because she got that nice syncing of all these systems. She was able to actually exhale and pelvic floor contract and then also get a good recruitment pattern of abdominals and transverse abdominals when she was doing the traditional core coordination exercises. So with her, it just took a little bit of unprogramming than programming to kind of get her back onto a better movement strategy so that she wasn't just using her diaphragm to grip and to give this pseudo response that she had this strength that she really didn't. And then putting obviously too much pressure on pelvic floor if you're just gripping with your diaphragm.
Now that you've got us all inspired that this is well within our comfort zone, that we can deal with this, but we might need a little bit more knowledge, what are some resources that you'd recommend PTs go to? You already mentioned two, but are there other resources for getting a little bit more in sync with training the pelvic floor, the breathing, and doing some more external physical therapy related to pelvic floor?
Yes. And I mentioned Julie Weeb. Julie Weeb has extensive information on her website about the pistoning effect of diaphragm in the pelvic floor. If you need more of a visual on that, she does a beautiful job with that. Susan Clinton also has a wonderful podcast called Tough to Treat that she's also a fellow. She's trained internally as well. So she's a great mind to follow. And she does a really good job on her podcast going through cases and clinically reasoning with her other colleague. Tough to Treat is her podcast, which is a great podcast. And then you can just obviously Google her. And then Sarah Hag is another therapist that she just treats externally, but she has some really good resources in terms of she has an incontinence book that is very patient friendly. It's sometimes helpful to give to patients, especially with our low back patients that we know there's a relationship there. Just gives them more information about what types of urinary incontinence are there, why this happens. And that's a great resource that I give out a lot to patients and even to even for myself, it was helpful to read when I was just getting into this. In terms of other resources, AAOMPT just developed the Pelvic Health SIG. So they're in the process of developing further resources to members and non-members, and that's being led by Kelly Wilson. She's trying to find a way to get that information out as soon as possible, but they're a relatively newer SIG, so they're just trying to get going. So hopefully within the next year or two, there'll be some information through AAOMPT and through our website that people can access easily.
That's something to look forward to, and that was a fantastic list of places to go to get started. Thanks so much for your expertise in bringing your passion to this topic and doing a wonderful presentation. Also, thank your colleague, Ashley, for her part in this too. She did a great job, but we're really appreciative of what you're doing for the Academy and just the enthusiasm and energy to bring light to one of these areas that isn't often as prominent in the orthopedic world. Is there anything else you'd like to add?
Yeah, I'm just very appreciative that I can talk about this topic. This is something that once you dive into it, you kind of find the famous PTs that are big into this world and they know way more than I do. So the list you mentioned earlier, and I'm so appreciative to Ashley Crew. There really isn't a ton of pelvic floor specialists out there. So I'm very appreciative that she was able to be with me because she knows way more about that world than I do. So it's very, very helpful to have these relationships opened.
Thank you for joining me and spotlighting the content for the conference. And I hope to see you next year and hopefully in person.
Yes, in Cleveland, right?
Yep.
Yeah, in Cleveland. Yeah, that'd be awesome.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.